I'm
Hello, welcome everyone. Thank you so much for joining us. We'll let folks join us and we will be starting it momentarily. All right, hello again and welcome. Thank you so much for joining us for our last session of our Take 10 series. It's Take 10 Transforming Care and Understanding Health Needs for Women in Recovery and Experiencing SUDs, Women's Health Matters. And today we will be having a panel discussion. Today's training is brought to you by the Great Lakes ATTC and SAMHSA. The Great Lakes ATTC and PTTC are funded by SAMHSA under the following cooperative agreements. The views expressed in this training are the views of the speakers and do not reflect the official position of DHHS or SAMHSA. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. I do have a few housekeeping items for you all. If you are having any technical issues, please individually message me, Alyssa Koala, in the chat section, and I would be happy to assist you. Questions for the speakers. We will be taking time at the end of the presentation today to answer any of your questions. So please put your questions in the Q&A section of your toolbar. The recording and PowerPoint will be made available on our website by the end of the week. If captions or the live transcript would be helpful, please locate that option using your Zoom toolbar. You will be directed to a short survey at the end of today's presentation, and we would greatly appreciate it if you could fill that out. And certificates of attendance will be sent out via email to all who attended today's session in full. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn, our YouTube channel, or our Spotify channel. I'm super excited to hand this over to our panelists. And to start off, we're going to be hearing from Odayme Quesada.
Hello, everyone. Give me one moment. All right. I hope you can see my slides.
Yep, it looks great.
Fantastic. All right. So my name is Dr. Odayme Quesada. I am a cardiologist at the Christ Hospital. I'm the director of the Women's Heart Center and also the Ginger Warner Endowed Chair in Women's Cardiovascular Health and assistant professor at the University of Cincinnati. And I'm very excited to talk about women's health matters, heart disease in women. Let's get started. So when we talk about cardiovascular disease, it's really important that we recognize that this remains the #1 cause of death in women in the United States. Heart disease continues to kill more women than all the cancers combined. And heart disease is the #1 cause, not just of older women. A lot of times we think about heart disease as a grandmother's disease, older women and men, but really it is the #1 cause of death, even in new moms. So right after delivery, heart disease is what's killing more moms than anything else. And it's important to recognize that heart disease death from heart attacks is actually increasing, especially in young women. So this is something that we have to be aware, especially in this population. The reason I bring this up is because although we think that people should know that heart disease is the #1 killer, believe it or not, when it comes to awareness, it's actually very low. So there was a survey data that was done between 2009 and 2019, and it essentially showed that even the awareness of something as simple as heart disease being the leading cause of death was 65. And that was a decrease and that decreased to 44% in 2019. So we saw a decrease in that knowledge. And the greatest decline was seen among Hispanics and Blacks. And also there was a decline in the awareness of heart attack symptoms. And this is not just among the population. This awareness is not just an issue of the common, the people, the patients. This is something that actually we see a lack of awareness even in healthcare providers, which is quite concerning and why it's important to recognize this. So when we talk about substance abuse, because that is the particular topic we want to talk about today. And we look at the trends for substance use and cardiovascular disease-related mortality in the U.S. What we can see is, so the overall is in this pink magenta color. and then the women are in the blue and the men are in the green. But essentially what this highlights is that unfortunately from 1999 to 2019, we're seeing a pretty steep, a continuous increase in the mortality rates when it comes to cardiovascular disease related mortality in substance use. And this is seen in both sexes, even steeper in men actually. And then when we look at this by different races and ethnicities, we see a very really scary incline in American Indian and Alaska Natives, with a sign of a decline at least from 2018 to 2019, which gives us some hope. But then looking at the different races, non-Hispanic, Black, or African American in the magenta color, again a very ongoing increase. Non-Hispanic whites in blue, Hispanic or Latinos in yellow, and then in this orange color we see the Asian or Pacific Islanders. But again, except for Asian and Pacific Islanders, we do see that ongoing increase. And lastly, I was very interested to look at what does it look like for different substances. So what we see here is that the steepest incline is actually in alcohol, as you can see in the green, and then that's followed by opiates. Cocaine is in the, actually stimulants is in that darker blue, and then in that more bright blue is cocaine, followed by sedatives, and then cannabis. But again, where we see that steep incline, especially, from 2018, 2019, is in alcohol. We see that in opiates, and then we see it in the stimulants and in cocaine. So it's important when we think about women's heart disease, that's my area of expertise. I always like to highlight, what are the differences between heart disease in women and men? And so I want to start by talking about risk factors. So when we think about cardiovascular risk factors, we think always of the traditional risk factors, which makes sense: diabetes, smoking, obesity, overweight, physical inactivity, hypertension, dyslipidemia. We'll talk about substance use for most of this talk in more detail, but I do want to highlight that now we're starting to recognize these emerging non-traditional cardiovascular risk factors, and a lot of them are actually female specific. And we're talking about adverse pregnancy outcomes like preterm delivery, hypertensive disorders of pregnancy, meaning high blood pressure at the time of pregnancy, gestational diabetes. So again, all of these adverse pregnancy outcomes are actually increasing a person's risk for cardiovascular disease. And for instance, in preeclampsia, we actually see that these women develop heart disease at a younger age. We also see autoimmune diseases, breast cancer treatment, depression, anxiety. Again, these are starting to be recognized as risk factors and are not specific to women, at least the last, but are just more predominant. Here's just a little bit about this idea of pregnancy as a women's first stress test, and really a clue into future heart disease. So as I was telling you, these adverse pregnancy outcomes, here's an example of hypertensive disorders of pregnancy. We know pregnancy is very common. More than 80% of women have at least one child. And when they develop these adverse pregnancy outcomes, it's as if they failed their first stress test. So what does that mean? That gives us a clue that these women that develop these adverse pregnancy outcomes, actually, as they get older, they're at a higher risk for heart disease later in life. And as I said, with certain adverse pregnancy outcomes, we're actually seeing heart disease develop at a younger age. And here's just an example of hypertensive disorder pregnancy associated with even a close to 4-fold increased risk of chronic high blood pressure, heart disease 2.5-fold, heart failure 4-fold. So again, these are concerning cardiac diseases that we worry about. I'm not going to go too much into this because I know it's going to be covered by one of our other speakers, but it's important to recognize that there's an increase in cardiovascular events with substance use in pregnancy. And so this JACC advanced paper in 2023, so pretty recent, broke it down by the different substance uses, and then it gave us the aggregate. So as you can see here, really any substance use during pregnancy was associated with a 1.6-fold higher risk of in-hospital cardiac event. Acute cardiomyopathy or heart failure was 2-fold higher risk. in-hospital major adverse cardiovascular events was 1.5-fold higher risk. And actually in-hospital maternal mortality was almost 2.7-fold higher risk. And so, and as you can see here, they do a very nice job of breaking it down. They actually analyze it by the different substances. And one thing to highlight, for instance, is the highest odds ratio when it comes to cardiovascular events was seen in amphetamines. Similarly, with amphetamines, we see the highest rate of acute cardiomyopathy, heart failure, with a 9-fold increased risk. And again, all of these substances increase a woman's risk during pregnancy of a cardiac event. So let's go into some of these different substances to try to understand what they actually do to the heart. We'll do this quickly. So when we think about cocaine, it's important to think about what it does to the heart and what it does to the blood vessels. So what it does to the heart, or one of the things it does, is arrhythmias. We also know that cocaine can induce acute myocardial infarctions, so heart attacks, and it can lead to cardiomyopathies, which can lead to heart failure. And then when we look at the effects on the blood vessels, it can lead to acute hypertension or coronary vasospasm. So there could be constriction of those coronary arteries, which again can contribute to that heart attack, to that MI. It can also lead to atherosclerosis, which is plaque buildup in the coronary arteries, and coronary artery disease as a result of that. Here's a study looking at particularly acute MIs in the setting of cocaine use. So it's important. This comes from the cocaine-associated chest pain study. They found that about 6 patients who presented to the emergency department with chest pain after cocaine use actually had a myocardial infarction. So this is something that, although not all cocaine use chest pain is a myocardial infarction, a large proportion of it is. And then in terms of how we should manage MIs, heart attacks, in a patient presenting with cocaine use, there's been some debate about this, but a more recent study from the National Readmissions Database from 2016 to 2017, with over 3,000 patients with NSTEMIs and a history of cocaine use, essentially reassured us that invasive approach and revascularization for cocaine-associated NSTEMIs was actually associated with a lower rate of MACE than a non-invasive strategy. And the reason this is important is because before this, there were some studies that suggested that there was fear about using PCI in patients coming in with cocaine, and whether there would be non-adherence to medication, which could lead to essentially subsequent MIs. And this real world data reassured us a bit, but of course more is needed. And then of course it's important to recognize that in cocaine, because of what I mentioned, there's that high risk of coronary vasospasm. Then beta blockers, especially non-vasodilatory beta blockers, are contraindicated if someone presenting with a heart attack in the setting of cocaine use. Moving on to amphetamines. So these can lead to cardiac arrhythmias, dilated cardiomyopathy, pulmonary hypertension, coronary vasospasm, and atherosclerotic coronary artery disease. So again, very similar to what we were seeing with cocaine. In terms of alcohol, how do we define alcohol? So heavy alcohol consumption is usually defined as 4 or more standard drinks per day for women and 5 for men. And it's important to realize that the impact on the heart and the cardiovascular system is actually dose dependent. So both persistent and episodic heavy drinking increases the risk of cardiovascular disease. And there's actually an increased risk of a heart attack in the 24 hours following consumption of 6 or more drinks on a single occasion. So again, that episodic heavy drinking that many times people think can be harmless can actually increase the risk of even an MI event. And and when we think about heavy drinkers, they're at a 1.5 more likely risk of dying of a stroke than those who abstain from alcohol. Then here we're moving on to opiates. So again, I think the most important part is the bottom piece. And then again, this is pretty recent from a JACC publication in 2021, where it pretty much highlights what we see with chronic use of opiates, and then what we see with abstinence withdrawal, and then with heroin and abuse. So with chronic use, there's sleep apnea, there's nocturnal hypoxia, there's hyperphagia, obesity, hyperglycemia. So these are essentially cardiovascular risk factors. And then with absence or withdrawal or with chronic use, of course, we can see acute MI, stress cardiomyopathy, arrhythmias like atrial fibrillation. With overdose, there's the risk of having sudden death, cardiac arrest or respiratory arrest. There's this deadly arrhythmia called torsade de Pointes, which these patients are a higher risk for. And then with heroin abuse, particularly, we worry about bacterial endocarditis and embolic strokes, which can have devastating results. When it comes to marijuana, the truth is more research is needed. These are just some of the hypotheses of how it could affect the cardiovascular system, but the reality is more research is needed in this area. But again, we believe that based on research, marijuana has the potential of course, concurrent hazards with other drugs, platelet activation, which can lead to MIs and stroke, oxidative stress, which can lead to damage of the vascular system, the peripheral artery system, hyperhidronetic state, which can lead to increased risk of arrhythmia, and then cardiomyopathy. But again, this one is one that I think the literature is in both. It's hard to really pin down at this time, essentially, the true effects. We need more work on this particular substance. And then when we look at heart failure again, this is one that you heard me mention throughout as we were talking about these different substances, because essentially all of these alcohol, tobacco, cannabis, cocaine, they can all lead to heart failure, especially with chronic use. This is just a nice little summary slide because as you can see, there's a lot of overlap between the increased risk of cardiovascular disease and the different types of substances that are being used. Some are more prone to causing, for instance, a particular cardiovascular disease, for instance, MIs, cocaine, as I mentioned, stroke. We worry about amphetamine use, aortic dissection, cocaine and amphetamine, same as pulmonary hypertension. With the arrhythmias, we worry more about amphetamines and alcohol causing those. And then cardiomyopathy, again, all of these can cause it, but alcohol is really the substance that is the most responsible. And then for hypertension, we see essentially the majority of these causing an increase in blood pressure. So now moving on to a little bit about differences in clinical presentation, because as I said, we went over the risk factors. Now, how are there differences in presentation? It's important to realize that women and men can have the classic Hollywood crushing chest pain, radiating up to the jaw with associated shortness of breath, nausea that is really hard to ignore. So of course you're going to go to the emergency room and get checked out right away. But it's important to realize that in women, we can also have symptoms that can be a little bit harder to really tease out. Many will say that they just had epigastric pain that they try to treat with PPIs and other over-the-counter meds. And because it didn't go away, they presented to get evaluated. Sometimes it could just be extreme fatigue. I've heard just jaw pain from patients of mine presenting with a heart attack. So these symptoms that used to be called atypical are actually pretty typical in women. So if they have any of these symptoms, it's important to be concerned, especially if there's been any substance use, which as we heard increases the risk of MIs, particularly cocaine. And then stroke, again, men and women can have the classic stroke symptoms like the face drooping, arm weakness, speech difficulty that are hard to ignore. But again, many times women are more likely to have these more subtle symptoms like vision problems, trouble walking, severe headache, general weakness, disorientation, fatigue, or just nausea, vomiting as their presenting symptom for a stroke. Lastly, it's hard for me to do any presentation without really highlighting something that a lot of providers don't know about, or the general public, which is that there's actually certain diseases, certain heart diseases that are actually more common in women. And these are the diseases that are less understood and less recognized. And that's actually my area of expertise. So I actually specialize in patients that have chest pain and open arteries or even heart attacks. And when they do an invasive angiogram looking for a blockage, they don't find a blockage. And so that's because when we do an angiogram where we visualize the coronary arteries, we're only able to see the large arteries. We're not able to see the intricate system of the microcirculation. And this microcirculation, if it becomes disease, which again, it can happen with substance use, given some of that pathophysiology that I went over, these patients can have chest pain and have completely open arteries. Many times they're dismissed, but what they need is specialized testing to actually look for coronary microvascular disease. And so that's one of my areas of expertise. And like I said, people can even have full-blown heart attacks that are often missed and dismissed because their arteries are open when we do an angiogram. But there's actually, these are pretty complex, and it's important to get to the bottom of the cause of a heart attack, even in the state of open arteries. And then last but not least, just to highlight, why it's so important that we talk about heart disease in women. And that's because there's very clear health disparities in when it comes to cardiovascular care. So we know that women are, when it comes to post-heart attack care, they're more likely to have lower treatment rates. With heart failure, we see the same thing. I mean, we essentially see lower rates of treatment across major cardiac diseases that we know exactly how to treat. And so what is the impact of this, of all of this? Well, essentially, as you can see here, we've seen, we had done a great job with when it came to cardiovascular mortality. Up to 2010, we saw that very nice decrease, but now we're seeing an increase in both males and females. And as I alluded to earlier, when we look at all-cause mortality, again, we're seeing that increase in both men and women. So a lot of work to be done when it comes to changing the statistics, but it's important to realize that 80% of cardiovascular disease is actually preventable. And it's important to, I always tell my patients, there's a balance. There's all the risk factors, but then there's all the things that you can do to change and reduce the risk, which is, of course, abstinence is key. Knowing the numbers to see the blood pressure, glucose, lipids, to see what is the patient's risk for cardiovascular disease. Physical activity is key. Dash in the Mediterranean diet, sleep, and then statins based on their cardiovascular disease risk. This is the Life Simple 7 that we always go over with all of our patients. And that's about it. Thank you very much.
We did have a question come through in the Q&A. Someone's asking to clarify, is research showing that pregnancy complications increase risk of cardiovascular disease, or that pregnancy complications show which patients are already at an increased risk?
I think it does both, actually. So I think what it does is that because a lot of patients are getting, people are getting pregnant at different ages, right? But essentially, someone may think that they're very healthy. A lot of times, young women are only going in for OB-GYN care. They're not really, a lot of young women or men don't have primary care doctors, even though they should. So they may think they're completely healthy. They're not getting their lab work checks, etc. They're not, they didn't ask about their family history to know if they're at a higher risk or not. So this adverse pregnancy outcome may be a clue that that person's not so healthy after all, right? Because I'm doing research right now looking exactly at that. Is someone's cardiovascular risk, those that develop at these adverse pregnancy outcomes, is their cardiovascular profile before they get pregnant actually not as healthy as they probably thought they were, right? But so it probably highlights someone is not as healthy as they think, but it also is almost like a two-hit model where even in a real healthy person, having an adverse pregnancy outcome does increase their future risk of cardiovascular disease. So I actually believe that is probably both. But believe it or not, there are patients that even if you measure all their markers before they get pregnant, they may be completely healthy and still develop an adverse pregnancy outcome. And because a lot of them are associated with like oxidative stress, inflammation, and this inflammatory storm, particularly preeclampsia, even diabetes, gestational diabetes, we have the sugar the issues with sugar. So all of these can actually change the vasculature and likely predispose them to cardiac events, regardless of even if they were healthy going into that pregnancy. Yes, family history is very key. I just mentioned some of the key traditional risk factors, but if we look at the ASCVD risk score, there's actually what we consider risk factors, risk enhancers, and it does a really good job at breaking down what are risk enhancers and what are risk factors. And so family history is considered a risk enhancer. There's actually really good data that's coming out on sleep. It's not officially a risk enhancer. So for instance, preeclampsia, hypertensive disorders of pregnancy, those adverse pregnancy outcomes made it into the guidelines as risk enhancers. And sleep is probably going to make it there at some point. It's just not there yet. But we know it's one of those things like Life Simple Sevens now includes sleep because we know it's so important.
Great. Thank you so much for that wonderful presentation. If we see any more questions come through, I know you are across the world right now, so I will send you any questions that might come up. So thank you so, so much. Next,
Thank
we
you.
have Elizabeth Krans.
Hi, everybody. Thrilled to be here. Going to share my screen. You guys see that okay?
Yep, it's perfect.
Great. Awesome. Thank you. Okay, so really glad to be here and just really feel privileged to follow that previous presentation because that was awesome. So I'm an OBGYN. I'm clinically trained as an obstetrician gynecologist. I also am clinically a board certified addiction medicine provider. So I'm going to speak from the perspective of an obstetrician gynecologist who also provides addiction medicine care to our pregnant, postpartum, and parenting patients at our maternity hospital in Pittsburgh. So one thing about substance use in pregnancy is a really unique time for all women. It's not unique for everybody. It's always a special event. And it's really important for a variety of health services reasons. So patients behave differently in pregnancy. All patients behave differently in pregnancy. If you were ever pregnant, I know you behave differently, just what happens. So we want to kind of understand how those behavior changes occur and if there's a way that we can use those for enhanced motivation for post-delivery ongoing behavior change. That's one of our objectives. We also have a lot of healthcare resources in pregnancy, which are well deserved. They should span throughout the life course, but we tend to have a lot more of them during pregnancy. So we have differences in Medicaid eligibility. Patients can become eligible just because of pregnancy status outside of income eligibility, which really brings the healthcare system into play for a lot of patients. And there's just a lot of opportunity in general. So as obstetricians, we really try to understand how we can maximize this highly resource intensive and behaviorally invested time. How can we use those things to maximize the effectiveness of the healthcare we provide to pregnant individuals to really enhance their long-term health, because pregnancy is critical, but the goal is to use that as a diving board to the forever health of women and their children. So the other thing to understand in pregnancy is that it's not like, oh, somebody used a substance and it's a really big deal. Substance use happens all of the time in pregnancy. It happens all of the time in general in our society, but it continues throughout the pregnancy period. So prior to pregnancy, we see about a 50% social alcohol use among reproductive age individuals. A quarter of women smoke tobacco or cigarettes, and then 10% have some kind of illicit substance use or using substances prescription medications without a physician guiding that. And then during pregnancy, we do see that behavior change occur. So we see decreases in those prevalence rates, but they are still very persistent. We still see persistent tobacco use, persistent alcohol use, and persistent illicit or non-prescribed unregulated substance use. So as an obstetrician, it's important to kind of level set everybody's expectations that we get lots of training on gestational diabetes, preterm delivery, preeclampsia, cardiovascular disorders of pregnancy, but we don't get a lot of training of something that's just as common as those things, which is substance use and how to really identify, manage, and treat patients with those disorders, which is the result of our whole system kind of being biased and turned away from this as just as important co-occurring medical problem as any of these other pregnancy-related disorders. The other thing about substance use was mentioned in the previous presentation is it's a very diverse concept. So it would be like a substance use with a capital S and U. We are biased to thinking about opioids, which has been, I mean, we have this crisis and has been increasingly responsible for a lot of the substance use related deaths. But that whole crisis has evolved substantially since the early 2000s. We no longer see almost any prescription opioid use. It's like a throwback. Now it's exclusively fentanyl and it's exclusively polysubstance use. Very few people are exposed to an isolated substance. They're almost always exposed to multiple substances at the same time, which increase morbidity associated with use behavior. So this is something from our research group looking at. So all of these patients had opioid use disorder or a diagnosis of the use disorder related to opioids during pregnancy. And this was the other co-occurring substances that were being used with opioids. And again, this is a little bit older data, but it shows a rise. Again, a lot of this is geographic, but stimulants, amphetamines, a lot of tobacco use, co-occurring cannabis use. Although you see a decline in cocaine use, some of that's regionally. You see co-occurring stimulant use commonly, but sometimes depending on where you are, it's amphetamines versus cocaine. So once we understand that this is highly prevalent and it's an issue for many, many pregnant individuals, we have to think about how we approach use disorders in general. And it's important to think of them as a complex chronic care process. So just like somebody who has any other complex chronic care disease, I think cancer was always the kind of home for this, but medical disorders are becoming increasingly recognized as really influenced by a variety of different factors, so multiple influences influencing the development of a disorder, and then that disorder therefore influences multiple different aspects of health. So here's a graphic that can be helpful to think about a complex care ecosystem. And this is one that we put together based on substance use, and just to demonstrate all of the different components that we think about when we're trying to develop a care delivery model to help this population. So key to that is medication, thinking about reproductive health needs, infectious disease needs, cardiovascular needs, behavioral health needs, physical health needs, etc., social and peer support. All of those things go in to care for somebody with a complex chronic disorder and really need to be considered when designing care plans. So most of my work, all of those things are important, but most of my particular individual work is focused on medication access, availability, and treatment in pregnant individuals. And that's really because as a clinician and somebody who does work related to delivery of healthcare, it's the most effective thing we have for opioid use. So, I mean, you just can't treat somebody who has opioid use disorder. You just really can't without medication. And so here are the medications that are FDA approved or available for opioid use disorder. The ones we use most commonly in pregnancy are methadone, which is a full opioid agonist. It has a lot of restrictive policies related to it because it is a full agonist, although we as physicians prescribe full agonists all the time. Oxycodone, Dilaudid, those are all full agonist opioids. But they're not relegated to specific treatment programs. So methadone is unique in that way. A physician cannot just prescribe methadone for substance use. It has to be dispensed through a a licensed drug and alcohol treatment facility, but it's a highly, highly effective medication. It works really well for a lot of people and is an important treatment option. Buprenorphine is another critical, the other most common treatment we use in pregnancy, which is a partial opioid agonist. It is not as quote unquote potent as methadone or other full opioid agonists. So due to that partial agonist activity, it has been allocated to be prescribed by any physician who has a license to prescribe medication, and it can be dispensed across any pharmacy, CVS, Rite Aid, you name it. So it's much more accessible, and it provides much more flexibility. There's also multiple formulations of buprenorphine. There's injections, which really have liberated a lot of patients from taking daily medication, which is a barrier to compliance. There are daily medication tablet and film formulations. There's just a lot of options. Buprenorphine has become very diverse, which is awesome and has provided patients with a lot of increased access to different formulations of medication. We also have a naltrexone, which is an antagonist. It's not used quite as much during pregnancy, but it can be used if it's effective for an individual. And then, of course, it's not for treatment, but naloxone is an important rescue medication, not for long-term use, but to save someone's life in setting of overdose. So it's important to understand that medications are, again, number one, we can't say it enough, medications are where it's at for opioid use disorder. And the emphasis on medications, we just have more tools, more medications for opioid use disorder. There's a lot of drug development for stimulant use disorder. We haven't really found the medication for other use disorders. Alcohol has several medications that we can use that can be effective. Tobacco has treatment alternatives, but thinking of medical management is how we really want to center on this, because that we really see better effectiveness rates. This is specific data in pregnant populations. We know it's highly effective for non-pregnant populations, but this is some data out of our team that shows with the use of medication in pregnancy. So on that bottom axis, 0 to 40 weeks, which is the duration of a full-term pregnancy. With every week you use medication in pregnancy, you see your probability of overdose steadily and incrementally decline. So it's incredibly life-saving. We also see pregnancy-specific outcomes decline with medication use. So this is the probability of preterm birth. So we know that the rate of preterm birth and other adverse pregnancy outcomes is higher in women who use substances. And so here is laying a layer of what if we were to look at with every increasing week of medication use, we see this nice, again, steady decline of the probability of preterm birth, which is associated with significant neonatal morbidity for these patients. And then here we see this didn't reach total statistical significance, but we see a lot of lower birth weight, growth restriction in this population. We did see a trend in that direction of decline. It just didn't reach significance. But this is just another area where we need to continue to do work. So the problem is only about half, this is work out of Massachusetts, but we see this in Pennsylvania as well. Only about half of pregnant women with opioid use disorder receive medication. So we know it is absolutely the most effective thing that we can do for patients, but many, many patients are not receiving that. And we do see disparities by racial ethnic groups. So one of our goals is really to expand access to medication, increase medication utilization, and as we've seen in some of this data, that is a direct correlation between reducing maternal mortality due to substance use and improving birth outcomes. So while I continue to harp on the importance of medication, medication really isn't everything, as I alluded to in that complex care diagram. We really need to be doing more for patients because, we're treating people, not receptors, although receptors are incredibly important. So here's another schematic about thinking about approaching this population as whole person care. And again, bringing in all of those different components of care that are critical to improving long-term recovery. And this is just some data out of our clinical program here. This is just outlining the percent of patients who are dealing with a variety of medical, social, and just kind of socioeconomic things that make their that can make their lives incredibly complicated. So we see high rates of criminal justice involvement, high rates of injection or intravenous use. A lot of patients have had multiple overdoses, significant behavioral and mental health needs, up to over 80%. And then I think we talk about this less, but we should talk about it more. Just basic primary care, dental care, just basic healthcare services beyond a lot of these social stressors are really underutilized for many of these women. And need for childcare, need for additional counseling, food insecurity, need for housing, need for transportation. All of these are can impact the ability for somebody to stay engaged in treatment, to continue to use their medication. And it's just a continuum of complexity that patients are struggling to try to overcome, and that they can't and shouldn't have to do themselves. So in pregnancy, so substance use in general is an incredibly stigmatized chronic disease, but in pregnancy, we just up the ante of that stigma. And so just stigma can come from a variety of different places, but we really see an enormous amount of what can be termed internal stigma. So that is just a complete lack of self-worth. So patients feel self-conscious, guilty, they have tons of self-blame and self-hatred. They think everything is their fault and that they are doing this to their baby. And it's really profound, and that can prevent them from wanting to talk about it, from wanting to present to care, to want to engage in what's going on with them with their social peers and relationships. It can be profoundly adversely impactful. And then, of course, they're constantly bombarded with external stigma, which is being stigmatized by people around them, including healthcare providers, family members, friends. I mean, you name it, making them feel awful about having a use disorder and being pregnant at the same time. I think really the biggest thing is just the first thing I do when I interact with patients is I tell them how proud I am and how thrilled I am that they are there and that they have allowed us to have a conversation, and how they have taken the step. If I'm having a conversation with them, they have taken a step to present for care. And that in itself deserves an enormous amount of congratulation. It took so much for them to be here, and I just do whatever I can to make them feel so proud of themselves for presenting for care, because you have to understand most patients are coming in with zero self-worth. And many times they look at me like they've never heard anybody say that before, or they start crying, So talking to patients about just what they have done to even get to the point to interact with you is such a huge achievement, and how proud they should be of those goals. Just being kind and supportive in a way that the goal is to make them feel proud and empowered. And it's really, it doesn't take much to do that and to use that language, but it can just really go a long way in somebody who may have never experienced a conversation like that. So words absolutely matter, and I know the panel is aware of this, but I think one component of this that's specific to pregnant individuals is talking about the baby. So we would never say that the baby is addicted. Addiction is a has a disorder with behavioral components, and babies don't exhibit addiction-related behaviors. It's just impossible. NAS baby, NAS baby. It's really this. There was prenatal substance exposure for that infant. To take it off of labeling the baby with an adjective, and it's more of the environment that the baby may have been. And then some of these other terms are incredibly important to make sure that we're not using them. And even if a patient uses them, which we see all of the time, we want to talk to patients about, we continue to want to use appropriate terminology. So we're not trying to use labels. Images matter. I think over time, clearly a lot of press and, whenever I talk to a journalist or talk about a story, I just, you don't need to be showing needles. All babies cry. That's like a thing babies do. So we don't have to put like a screaming baby next to a conversation about substance use and pregnancy. That's not specific to substance use, like it's what babies do. So I think these decisions are conscious and that's the way, media is often driven, is to create emotional responses through images like this. But I would just kind of challenge everybody, if you're in conversations about something being put in print or language being used, it's your responsibility. We got to correct people and just indicate that these are not appropriate images and they don't help anything. So spent a little bit of time on stigma here, but it really is so critical you wouldn't believe how much patients can just totally change their outlook on their care process with just being kind to them. I had a conversation with one of our fellows and we were just talking about the field of addiction medicine in general. And these are people who are going to do all of their clinical care related to addiction. And addiction medicine is really not that hard or complicated. You just have to be nice to people. And that's really the only thing that medications are critical and is a key part of what we do, but even more is just being nice, which is surprising that many people aren't. But anyway, so healthcare providers, patients, I'm in the system, I'm part of the healthcare system. I want patients to be in the system, but in order to do that, we have to really model and behave in a way that encourage patients to present for care. So they're really more likely to talk to you if you allow them the time and space to talk about their experiences and not be judgmental and just listen. It really is a chronic medical problem that has lots of physiologic impact. The brain is completely changed. Medication is critical. Things have happened physiologically. It's not a decision that results in a chronic disorder. And so patients need to receive that education so that they take away that responsibility that's often put on them related to it being something that they can control because they can't. So I love ending with this quote because I think it's just so nice when we think about pregnancy, is you are talking about two people that are connected. So that's why you don't talk about the baby as something separate. You don't talk about the mom as something separate. It's really this kind of interconnected unit. And when you're talking about pregnancy, you're talking about how to do the best and right things for that unit because they cannot exist alone. So I think when we think and approach pregnant parenting or any kind of family unit, it's about how best that care delivery process touches all of those people and really fosters the success for that whole unit moving forward. And I will pause there. Any questions?
It looks like we did have one question in the chat. Are there any adverse effects to the fetus if naloxone is given to mom while she is pregnant?
It depends on the clinical. So meaning that person is getting like is in an overdose situation and giving Narcan, or just trying to understand so overdose will kill mom and baby, right? So we have to stop it. And giving somebody naloxone is absolutely 100% indicated in pregnancy to save the woman's life. So it avoids the adverse effect, and I'm not trying to, but so it should never, pregnancy is never a contraindication for naloxone. Is there an effect of giving, so because baby is exposed to those substances, so there is some kind of response which we don't really know and cannot characterize well. All kind of in utero responses, the understanding of those responses beyond something very rudimentary is really not well described, because we have no way of monitoring. We have monitoring tools for babies based on placental perfusion and basically the model of hypoxia. We don't have, and we can use those tools like ultrasound and non-stress tests. We just don't know how to use those tools to monitor response or kind of exposures related to substance use. It's an important question, but I think clinically, 30,000 foot view, everyone should receive Narcan if there's a concern about overdose. But I think sedation is different than overdose. And in clinical settings, sometimes we see a little bit, if somebody's sedated, but they still are fine with vital signs and they're clinically fine, you give overdose if somebody's unresponsive, and give Narcan if somebody is unresponsive. But that was a little bit rambly, but happy to talk more.
Thank you so much, Elizabeth. That was wonderful. If anybody has any other questions that come through, we'll make sure we get those questions to you so we can get those answered. So thank you so much for that wonderful presentation. Up next, we have Melinda McMichael.
Hey everybody, how are you? Thank you so much for having me here. I'm going to be sharing my screen here with you all. One moment to pull this up. Second here. Okay. Share screen. Yeah. Okay, are you guys able to see it?
Yep, it looks great.
Wonderful, perfect. Thank you so much. My name is Melinda McMichael, and I'm happy to be here with everybody today talking about peer doula support for pregnant and postpartum women that are affected by substance use disorder. First, I want to talk a little bit about what peer doulas are and the two different dual roles. A doula is a non-medical professional who provides emotional, educational, and physical support to pregnant people and postpartum people before, during, and after childbirth. And a peer supporter is an individual with a life-altering lived experience of psychiatric, substance use, or other challenges that has made a personal commitment to his or her own recovery, and who also has a desire to use what they have learned from their own lived experience to assist other people in similar circumstances. So a little bit about myself. I work here in Chicago, specifically with pregnant and postpartum people that are affected by a substance use disorder. I am actively in recovery, and I have been sober for over 7 years now, and I support women here at Haymarket Center who have gone through similar challenges that I have faced in my recovery journey. So the roles of doulas in addiction recovery. So there is a lot of benefits from having doula support with women that are in recovery. And some of those things look like providing them with emotional support. And, you know, as peer doulas, we create safe and empowering environments for our clients, and that begins with trust and establishing a foundation of compassion and respect. Many women in recovery or experiencing substance use disorders may feel vulnerable or judged. So it is extremely important for us to create a space where they feel heard, valued, supported, safe. And this can involve, you know, providing them with the emotional support, which is giving them a non-judgmental presence, active listening, and coping strategies. So doulas provide a safe space for individuals to express their feelings, their fears, and experiences without judgment. We often offer empathetic listening, which helps our clients to feel heard and understood, and that can alleviate feelings of isolation. Doulas also assist with developing healthy coping mechanisms to manage their stress, their cravings, their triggers, and different emotional challenges that are often faced during the recovery process. Doulas also provide advocacy and empowerment. It's extremely important to advocate for this population and empower them to be better and to feel better about themselves, increases their self-esteem. So we do that through personalized care, navigating them through different resources, and providing them with education. So, as doulas, we need to be able to advocate for the individual across from us's needs and their preferences. This can ensure that their voice is being heard. We can help them navigate different resources in the community, such as support groups, therapy, different community services, 12-step support meetings, making sure that they have connections to different medical care services, and this empowers them to take charge of their own recovery journey. And then the guidance through the recovery process. Recovery and aftercare planning is extremely important. Relapse prevention and providing them with holistic wellness support. So we can assist individuals with understanding the various treatment options that are available to them and create personal recovery plans that align with their own personal goals and their own personal needs. We can help identify different triggers and strategies to avoid relapse, and that often creates resiliency and long-term recovery. And we can also encourage the integration of holistic practices such as mindfulness, nutrition, physical activity, integrate that into their recovery process, and that can promote an overall wellness and well-being. Okay, let's see here. There we go. Oh Lord, let me see. There we go. All right, let's do it. Okay, some benefits of peer recovery doula support. So let's see here. Okay, benefits. So improved mental health outcomes. Some of the improved mental health outcomes that we have seen with our patients is emotional stability, increased self-esteem, and stress reduction. So being able to provide consistent emotional support can certainly help reduce anxiety, depression, and feelings of isolation, which are commonly experienced during early recovery. We offer encouragement and validation for the clients that we serve, and this helps individuals to build confidence in their own ability to navigate challenges and to make positive changes for their life and for their families. And just having our presence there alone can help lower stress levels and contribute to better overall mental health and well-being. Some enhanced coping strategies that we provide. We help with skill development, personalized approaches, and we support them during different crisis situations. So we can teach practical coping techniques like mindfulness, breathing exercise, sometimes grounding techniques, and this can help individuals manage cravings and support them when they're having emotional distress. We'll work with clients specifically to help identify different triggers and develop tailored strategies for helping them deal with these things in an effective way. And we can also provide immediate support during moments of crisis, which helps individuals stay focused on their recovery goals. And another benefit for recovery support is increased retention in recovery programs. So that looks like continued engagement, accountability, community connections. By being able to provide them with ongoing support, doula can motivate individuals to remain engaged in their program, which reduces dropout rates. That's home visiting, phone calls, follow-ups, assuring that they have their needs met, doing needs assessment. We can also help them with their accountability by helping them set goals and holding them accountable for those goals. And that creates a sense of commitment to their own recovery process, which also increases their self-esteem. Community connections, connecting clients to resources and programs in the community. It takes an absolute village. Myself and my team members are very well resourced in the community. We do outreach. We speak to other like-minded people, birthing centers, different hospitals. We're engaged in our own recovery program, so we know where 12-step support meetings are, and helping our clients get connected to those services and those programs increases the retention for them to continue to engage in these services and stay connected. Okay, here we go. This is one of my favorite things to talk about, is the reality of the challenges that are often faced by this population. And there we have it. So women in recovery from substance use disorder often face a range of challenges that can greatly impact their journey to sobriety and their overall well-being. Individuals are a lot less inclined to receive support or to engage in medical care when they are pregnant, because there are a lot of fears associated with substance use disorder and pregnancy. And one of those things is the fear of the child being removed from their custody. Many women fear losing custody of their children if they seek help for their substance use, which can often deter them from accessing the necessary treatment and support services. And this fear is often exacerbated by past experiences and stories from other people who have faced being a part of the child welfare system. There is a mistrust for medical providers. Women in recovery may have had a negative experience with healthcare providers, leading to mistrust or reluctance to engage with the medical system. And they have legitimate concerns about being judged or stigmatized for their substance use, and that can often hinder open communication with healthcare professionals. Lack of support systems is another reality that our population faces. A lot of times when our clients come to us to receive support, we are generally the last house on the block. Their family has not been supportive of them. They have stopped helping them, and they oftentimes have not a lot of people in their lives to help them. So the lack of support of the family and community networks can leave women feeling very isolated and without emotional or practical support, which is often needed during recovery. And this isolation can make it difficult to maintain motivation or accessing resources such as things like childcare, transportation, financial assistance, which is we do a lot of connecting them to resources to get daycare, to get WIC, make sure that they're connected with DHS so they have medical care, things of that nature, navigating their healthcare systems to help schedule rides, to ensure they have transportation so there's no barriers for them to get back and forth to medical appointments. Another reality and challenge that they face is, we heard it, from the other presenters, stigma and judgment. Women often face societal stigma related to both substance use disorder and motherhood, and that can lead to feelings of shame or guilt. And this stigma can be a barrier for individuals seeking help and can negatively affect self-esteem and mental health. Mental health challenges is another challenge that they face. Co-occurring mental health issues such as depression or anxiety are common and can complicate the recovery process. Also, accessing integrated care that addresses both substance use disorder and mental health can be very challenging. And then adding the pregnancy factor into things complicates the process as well and instills a lot of fear. And what I have seen with working with this population over the last 6 years is a lot of times when they come to our facility and they're pregnant, they are not able to take a lot of mental health medications during pregnancy because it's harmful to the fetus. So they come here with having mental health instability and coming off of, you know, whatever substance that they were taking, and it's very difficult to get them stabilized, and that's when they need the support the most. And trauma histories. Many women in recovery have experienced trauma, which can influence their substance use and their recovery journey, and addressing trauma through appropriate therapeutic interventions is extremely important, but not always readily available. Let's see here. So there are some specific approaches to support and respect our clients. So some things that we do again is education and advocacy. We educate individuals about substance use disorder. And I do want to share that substance use disorder is just like any other medical illness. People don't choose it, they do not deserve it, and it is not their fault. And it is certainly was not a decision that they made. So being able to talk to them about the disease of addiction, what that looks like, is extremely important, and advocating for their needs is crucial. Trauma-informed care approaches is extremely important as well. Our staff here at Haymarket Center, we look through things in a trauma and care way. There are certain practices that we have on our residential units with our counselors and our therapists and our providers. And we are trained to recognize signs of past trauma and try to avoid re-traumatizing them and triggering them with yelling and languages and different actions that some people are accustomed to in society. Emotional support, providing them with emotional support and practical assistance, helping them create birthing plans, recovery goals is extremely helpful, and ongoing postpartum support, doing home visits and checking in with our clients regularly after delivery ensures that they feel supported during their transition to motherhood. Peer doula support in Chicago. We heard a lot about the prevalence of substance use disorder and the need for individuals to stay engaged and have support. This is happening everywhere, not just in Chicago, but specifically in Chicago. There are a lot of programs specifically tailored to meet the needs of pregnant people with a substance use disorder. Chicago offers a range of different treatment options. We have different rehabilitation centers, different outpatient programs, support groups. There are a lot of different community organizations that provide resources for individuals that are seeking help. And we do our best here within our agency with our peer doula programs to learn what those resources are so we can connect our clients to people that are going to help them in an appropriate way. Efforts are being made to address disparities in access to addiction treatment, particularly among marginalized community. And there are different initiatives aimed to improve outreach and provide culturally competent care. At Haymarket Center, we accept all individuals despite their ability to pay. So even if they do not have insurance, we still welcome people to come in and get help for their substance use disorder, and pregnant people and women and children are a priority. And a little bit about the program that I work with PPW and the STAR program. It is a wraparound program that is uniquely designed to support pregnant and postpartum individuals struggling with substance use disorder. And it recognizes the unique challenges faced by this population and aims to provide comprehensive support. And there are some other doula initiative programs that are out there that also are trained and skilled to work with pregnant and postpartum people with a substance use disorder. And I know that it is going to be a thing nationwide, and this is going to take on and go all over. I just believe in that because it is so important for people to have the support that they need at this very important time, and having people with lived experience who have gone through this journey and who understand what it's like certainly sheds away and alleviates the fear of judgment and self-hate. Working alongside healthcare providers, we love the village, we love the community. It takes a village to support this population. By working alongside healthcare providers and building a support network, we can play a very important role as doulas in enhancing the recovery experience for individuals facing addiction. Our holistic approaches not only addresses the immediate needs, but it also promotes long-term wellness and resiliency. And we can complement each other. We complement the clinical care that is offered by healthcare providers. We provide advocacy, we act as liaisons for our clients, and we collaborate effectively with a lot of different healthcare professionals, including doctors, nurses, therapists, things of that nature. Doulas can accompany clients to medical appointments, provide reassurance and assistance in navigating the discussions about treatment options, medication management, and follow-up care. I do want to share that our PPW and our STAR program is nothing without the village that surrounds us, that equally supports us and our clients. Without all these services, we would not be able to be as effective in the work that we do with our families. And it is extremely important for all of us to come together to provide the support that these lovely individuals need. See here, and these are just some case studies that I wanted to throw in here from some of clients that I worked with, and these are people who had no idea really what a doula was or that the support was available to them. And I'm gonna just read them for you. I didn't know what the term doula meant until mine walked in the room, but I was 3 months pregnant with my daughter. She brought a bag of snacks with her, so I probably would have signed up for anything. It was my first time having a baby. The father was in jail, and although I am blessed with a family who were supportive in every way during recovery, it was hard knowing I was the only one excited about my first child. For me, having a doula meant I had access to programs and assistance, knowledge about parenting and postpartum, and a structured and stable program to follow me, and that prepared me for motherhood so I could focus on my recovery. Today, my daughter is 5, and I still use knowledge from my doula every day. My doula was an amazing part of my pregnancy. I feel like she was the only true, constant person that was present. I spent most of my pregnancy in jail, and when I came into Haymarket, she welcomed me with open arms. My daughter's father was such a mess at the time, and she really helped me keep my stress down, all the way down to the last push. She was the one person that was always there for me, that I could always count on, and I will be forever grateful. Well, I would like to say that having a doula was like having a companion, not just a doula. It was my doula and her personality that made me feel safe. She was easy to get along with and made me comfortable. And I always had someone to talk to no matter the situation. She had my back and fought like no other for me and my daughter. She helped shape me to be the woman that I am today. So those are just a little bit of case studies for you to see. Thank you all so much. It was a pleasure sharing with you about this wonderful work that we do here in Chicago. Thank you very much.
Thank you so much, Melinda, and thank you all for joining us. Up next, we have our presenter, Kelly Lemon.
Hi, everyone. Hoping you can hear me and you should be able to see my slides. I appreciate everyone coming into the session, and I know that we'll probably go a little bit over today. They put that in the chat. I'm actually going to go through my stuff pretty quickly because I really value everything that Dr. Warshaw has to bring to you guys. So I'm going to go through my stuff quickly, and at the end of my slides, I do have my email address, and if you have any other questions about anything that I go through, you are absolutely welcome to email me. So I am a certified nurse midwife and women's health nurse practitioner. I live and work in West Virginia. And so I'm going to offer to you guys a little bit of perspective on midwifing recovery. And anytime I'm going to come from the perspective of a midwife, I do always like to go a little bit over what that is. I do love the definition of a midwife, which is one that helps to produce or bring something forth. We are both a noun and a verb. And the word literally means with women, or to be across from women whenever you look at that word breakdown. People will say that you're going to midwife something in that meaning they want to really nurture something and care for something. And I think that that term can really hardly be applied to working with a recovery population. When you want to know what a midwife is in terms of somebody in the healthcare setting, that is someone that is specifically trained in the care of female healthcare across the lifespan. We do joke that we take care of people from menarche to menopause. So from when you first get your period to when your period's long gone. The really gem piece of our care is that we do have really specialized training in the perinatal period. So pregnancy, labor, birth, and postpartum, with also that focus on primary care and sexual and reproductive care. Something that I see really prevalently is that when people are in that perinatal period, when they are getting pregnant and raising babies, they tend to slack off on their own healthcare needs, and most of them will not have a primary care provider and will not see anyone or meet their needs. They are all in on their kids, and all of their children have their needs met, but they will neglect themselves. And so in that instance, usually their midwife ends up being their primary care provider. And so we're kind of in the confines of a pregnancy, often trying to help manage many other moving parts. And that is something that we heard about earlier when we were talking about maternal health conditions with cardiac issues, right? There are a bunch of different types of midwives. I am a certified nurse midwife, which means I'm a nurse practitioner with that specialty training. If you are ever curious about the different breakdowns of different types of midwifery, which all the different types of midwifery are beautiful, just depends on what your client needs are and making sure that we're doing appropriate levels of care. But if you're ever curious about all the different pathways of midwifery, there's a very, very quick breakdown for you. But what you're going to see in the healthcare system, what you're going to see with people who are providing care in a hospital, a clinic, in treatment is going to be your certified nurse midwife. A little bit of just about me is that there's a little bit more hats that I wear, so you can be more than just a midwife. You might be wondering as we're going through this, great, so you're a baby catcher. What's your relevance for here? Well, don't worry, I'm going to tell you. So I do a little bit of teaching. I do catch babies. Over the course of my career, a lot of my focus has shifted into taking care of individuals with substance use disorder and those that are in recovery. So really midwifing recovery is what I like to think of as I mainly do. And I think that the beauty of me kind of being your almost tail end speaker as we've went through all these different lovely care providers has been that I look at midwifery as kind of being in the middle of that web, and that we can really help to connect people to everything that they need. Since I am in West Virginia, we have very high rates of substance use, which is how I got engaged in this work. Some stats for you if you're interested in it, but take my word on it, West Virginia is doing pretty poor in in all things, we have really high maternal health care deserts, high rates of poverty, high rates of substance use. At one point, we led the nation in overdoses, which is not something that you want to be known for. The spin around on that is that we are now, with all of the work that we've been putting forth in our state, we are now one of the few states in the country that is seeing a reduction in overdose deaths, which is a beautiful thing. Part of the reason that we've been able to achieve that has been because of increasing access to treatment, really increasing access to care coordination services. And what I mean by some of those is we have a statewide program that's called Drug-Free Moms and Babies that was made by the West Virginia Perinatal Partnership. It actually got called out by our state leaders as one of the key programs that's really helping with rates of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. And as we heard Melinda talk about, and as we heard Dr. Krans talk about, those enhanced care coordination programs helping link people to all the different community programs they need are essential in working with your recovery population. A lot of those programs are spearheaded by midwives. I help with our Drug-Free Moms and Babies program here at WVU. Making sure that we have increased access to treatment for pregnant people, something that Dr. Krans touched on. I am a midwife that does treatment. And so expanding the treatment options for people that are familiar with prenatal care needs is important. And then making sure that we're doing really enhanced screening, which you're gonna maybe hear a little bit about from Dr. Warshaw, opening up those conversations with people to really try to meet all of their needs, all of those social determinants of health that we heard Dr. Krans touch on, to get all of those complex needs wrapped around. So the reason that I feel that midwives are essential in the recovery conversation and how everybody is able to midwife recovery really leans into that midwifery model of care. So if you were curious of what that looks like, this is the American College of Nurse Midwives philosophy of what midwifery care is. And I pulled out the key pieces for this. So continuous and compassionate partnership with patients. When I am taking care of somebody, usually I introduce myself, I tell them who I am, and I go through what working with me looks like. And one of my key things is this is a partnership. We are a team. I am not a dictator. I am not coming in to tell you absolutely everything that you have to do. My job is to come in and give you the best evidence, treatment recommendations from a healthcare standpoint, what I would recommend. You are bringing to the table all of your expertise on you, your lived experience, what you know to be true for yourself, everything you know about your history, and we are meeting in the middle to make a plan. And so that partnership is essential in your classic midwifery relationship with a prenatal client. It is especially crucial when you're working with somebody with substance use. Making sure that we are recognizing the importance of that interdisciplinary and collaborative approach. You can see that demonstrated literally in this webinar panel. We've had people from a variety of different specialties within this discussion. And so a key cornerstone of midwifery is being able to do appropriate health assessment risk, being able to identify when somebody needs something else. So a core part of my training is understanding what's appropriate for my scope, what I definitely need to get some help with. So what do I need to collaborate or consult with? And what do I need to full refer for? So I always tell my people that I work with, you can bring any problem that you have to me. I am not always the person that can help manage everything, but what I can do is connect you to the people that can. So I like to think of myself as air traffic control whenever I need to. Making sure that we are centering everything that we're doing on that individual's needs, and again, guided by good evidence-based practice and research. The thing that I think that we do differently than other realms of healthcare is we call it in midwifery, the noble art of doing nothing. So knowing all of these beautiful treatments and interventions and medications and all these things we have in our back pocket that we can do to jump in and help you and treat you. But knowing when we should sit on our hands, when we don't need to do anything, when we need to be patient and just be there in a supportive role, and letting that person also communicate and guide with us what they need. So good balance, and always having that therapeutic presence, recognizing how much power we can bring in just having presence, a consistent person, trust formation, and skillful communication. So with midwifery, one of our other strengths, I think, is understanding normal physiology versus abnormal physiology. That goes in again to the art of doing nothing and knowing when something's physiologic versus pathologic, and knowing how to work with other teams and taking on that holistic approach. Really quickly, if you were somebody that is a nurse, any kind of nurse practitioner or PA, there are different pathways that you can take to become a recovery treatment provider. You could do enhanced training, you can do certifications, you can do mentorship, which is something that I leaned really heavily into in working with individuals. So really quickly, thinking through, I've mentioned midwifing recovery. What does that mean and what does that look like? And these are concepts that, regardless of if you're interfacing with somebody in a healthcare setting, as a social worker, I'm someone that's really big on what's my list of things that I can physically take away from this and that I can do. When you are engaging with somebody, regularly going over those social determinants of health, recognizing that everything is going to impact how they are able to come to treatment, how they are able to show up for their recovery, how they make it to your clinic or your office or your advocacy center. What's their transportation like? Do they have healthcare insurance? Do they have somebody to watch their kids? What's your scheduling like? Is it flexible or rigid? Does it make it hard for someone that might be late all the time if they're relying on public transportation or other rides? Understanding what their situation is with substance use, intimate partner violence, coercion, and mental health, as all of these swirl together. And you're going to hear a little bit about that from Dr. Warshaw. And understanding that there's high rates of trauma and prior abuse among individuals that are accessing treatment. We have the ability, anytime you're interfacing with somebody, to be able to connect them to the next resource. So being really engaged in your community, knowing what your resources are. And that's something that I've been working really heavily with my clinics on, a pilot study that I'm lucky to be working with Dr. Warshaw on, is how do we help connect people to the community resources? How do you find them? How do you not only just know a number to give somebody, but how do you know who they're reaching out to, what the name of the person that's going to take that phone call is? How do you get a warm referral to where you're not just blasting someone out into the world, but you're actually able to confirm where they're going, who they're talking to, and what services they're going to get? And how are you following back up with them to make sure that they received those services? Giving education anywhere you can. And I think that this is the pitfall that happens a lot in, especially our healthcare setting. I know that all of my other healthcare providers on the panel can definitely probably attest that we work and live in a healthcare system that doesn't incentivize education or the time that we get to spend with people. It is very quantity driven. You are in, you are out. And the first thing that goes by the wayside is education. When you are working with somebody, especially a pregnant person, any education that you can provide to them to help them understand what their situation might be, and I'm going to dig into that a little bit more, can be really helpful. And then always coming in with that non-coercive counseling whenever you're talking to them about any care that you're going to give. For a midwife, that's going to be non-coercive counseling around contraception, safe conception, medications, what to expect when they come into the hospital, etc. And I always like to come in with an example. So if I'm just seeing somebody for an annual exam as a midwife, ways that I can midwife recovery is, sure, you can come in and out and I can give you a pap smear. Easy peasy. Hopefully, side plug that everyone's going and getting their preventative healthcare visits, and everyone that has a cervix is getting their pap smear. And if you are, you could go in and out very quickly and just have your visit. Or in an ideal world, someone's going to midwife you and they're going to ask you all the questions about how you're doing. And in that, they might ask you about if you're having any depression, how you're coping, how you're feeling. Maybe they give you a standardized depression screen and that opens up a conversation. And then you start talking about stressors at home, looking at them as a person in front of you and not just boxes we're checking. And then you start talking about, with all those stressors at home, how are things with their partner? And they could talk about how their partner might be harming them or emotionally or mentally abusive to them. And then maybe you start talking about how they're coping with that and centering a conversation around a lot of people use substances to cope. How is that starting to affect your life? And then before you know it, maybe you came in for a pap smear, but I sat with you, I talked with you, I built trust. And we were actually able to identify that maybe you're experiencing depression, some abuse. We're starting to use substances in a way that's affecting our life, and I can help you with those. I can give you warm referrals to treatment for depression. I can talk about depression medications. I can refer you to a treatment provider for substance use, and I can refer you to counseling to help with all of that. And I can refer you to a domestic violence advocate. So many different ways that we can not have to solve it all, which is what I think we get afraid of, but the ways that you can just take care of somebody and refer them to where they're needed. Specifically for pregnant patients, all of my coworkers are always like, well, I don't feel comfortable doing prescribing, and that's the only facet of treatment is just giving them meds. So I just send them for treatment, and that's that. I send them to Kelly Lemon for pregnancy treatment and we're done. And something that I really like for people to keep in mind is that there are a absolute variety of ways that you can just within your like perinatal care shell help to take care of individuals. Going over the safety and efficacy in treatment, going over what to expect for pain control. What do you offer at your facility? Same conversation you'd have with hopefully any patient that's going to have a baby, because having a baby can hurt. But taking that one step further, giving them information on what meds are available, finding out who their treatment provider is, getting a release to talk to their treatment provider or giving them a letter or a printout of the options so they can make a pain control plan with their treatment provider. Making a plan for what CPS notification looks like at your facility, how long they stay in the hospital, who's going to come and round on them and talk to them about case management. All those little pieces that we kind of don't think about can be really, really helpful in midwifing recovery for somebody, in making sure that they feel supported throughout. One of the key strengths that I like to bring to the table as a midwife, I'm going to skip ahead just for the sake of time, is I see a lot of people that have some reluctancy with their buprenorphine medications. This is, I think, a strength that I bring specifically over to the ladies that I treat, is that they'll have a lot of adverse symptoms. And as someone that has went through withdrawal before, they will a lot of times have symptoms that are very reminiscent of withdrawal, and they'll be really afraid that their medication isn't working. Other treatment providers will often be afraid of the patient going through withdrawal and will up the dose very quickly. And it may not work. And a lot of times those symptoms are actually just discomforts of pregnancy, where if you have that deep understanding of the physiology of what's happening in pregnancy, you can offer a lot of recommendations for how to manage those. So here's an example of just like a table that I have that I usually give to my students that I take care of. So very simply, you can see over on the left-hand side, these are all the different discomforts of pregnancy. It's a glamorous time. You can compare and contrast that to what is a common symptom in withdrawal and what is a common symptom that's a side effect of a medication for an opioid use disorder, such as buprenorphine. And so if someone's having tremors or trembling, a lot of times they'll think, oh no, am I starting to have withdrawal, or is this a side effect of my medication? That's also something that can happen in pregnancy. Let me help you with these really low-hanging fruit, easy things that we can do to help to take some of those discomforts away. And if they're not helping, then we look at adjusting your medications for opioid use disorder, or we reach out to your treatment provider and try to collaborate on what to go in that regard. So lots of different ways that you can use your expertise, even if your expertise isn't necessarily directly in substance use, that a lot of my colleagues actually can give a little bit more to somebody and enhance that care without really realizing it. Sorry, I sped through my stuff because I really want y'all to be able to hear from Dr. Warshaw. If you have any additional questions, I've got my email up here for you, and I'm happy to answer just a few before I turn it over.
Thank you so much, Kelly. That was wonderful. If I see any questions pop up, I will reach out to you. Perfect. And I would love to hand this over to our last presenter, Carole.
Thank you. Let's see. Let me make it do, wait. Okay. This is working. It's sharing.
Yep.
Great. So thank you for those of you who are staying and for those of you who decide to listen afterwards. I'm Carole Warshaw. I'm the director of the National Center on Domestic Violence, Trauma, and Mental Health. And I'm a psychiatrist, former internist ER doc. But most of my work now, aside from a small practice, is focused on training, TA research, policy. But part of what I want to talk about is why it's so important to address and incorporate an understanding of abuse and violence across the lifespan, trauma, and particularly intimate partner violence into any work that's addressing mental health and substance use in the context of perinatal care. Part of my kind of passion around this is coming from a number of different experiences. When I was on the Federal Maternal Mental Health Task Force, that I think ended, in January, but it was very hard to get people to integrate an approach to addressing abuse and violence and trauma across the lifespan, even though it's so prevalent among women who were pregnant and postpartum. And part of the focus was on evidence-based screening and referral without having a deep understanding of how all of these issues intersect. And another issue, it comes from being on the Illinois Maternal Mental Health Task Force. We have a violent deaths committee that's focused just on suicide, homicide, and overdose, which are leading causes of maternal mortality, and seeing time after time where these tragic situations where women die because they fall through the cracks, because there isn't an integrated approach, even though there are really good care providers in different systems. So it's really critical to make sure that we understand how these issues intersect. So what I'm going to do, the first part is provide a kind of framework for looking at these issues together, and the second part will be at least some kind of basic level of things we can do to address this in clinical practice. So first of all, many of you may be aware of this, that there are very high rates of intimate partner violence and other lifetime trauma among women who are accessing mental health and substance use disorder services, and among women accessing perinatal care. We also know that trauma and IPV have significant mental health and substance use related effects, and IPV has its own, the research shows it independently has significant effects. We also know that experiencing abuse by an intimate partner during pregnancy and the postpartum period really increases the risk for maternal depression, suicidality, anxiety, PTSD, substance use disorder, and opioid use disorder, and the risk of maternal mortality from suicide, homicide, and overdoses. And experiencing multiple types of trauma, which many women experience, further contribute to these risks. So, often we're looking at things as correlational studies, like these are all without looking at how they're integrated or what is contributing to them. So part of what we're bringing to this conversation from our research is that abuse that's targeted specifically towards a partner's mental health or substance use is really common, unfortunately, and it's a major contributor to the development of mental health and substance use conditions, and compromises treatment access and effectiveness. And this is just the summary, but I'll break this down in a few minutes. So that's part of why it's so important to have integrated approaches that address all the things. And I know Dr. Krans and Kelly, you've talked about this, and both of you are partners in our pilot studies of looking at how to incorporate responses to mental health and substance use coercion into perinatal and perinatal substance use disorder treatment. So these are summary slides of the research on the prevalence of intimate partner violence in both substance use disorder treatment settings and mental health settings. And you can see they're very high. The ranges have to do with completely different study designs and definitions. But just if you're working in those settings, think about, is this percentage of people that you're seeing, are you actually recognizing that they're experiencing intimate partner violence? We also know from looking across studies that there are much higher rates of a whole range of mental health and substance use disorder conditions. So rates of PTSD, major depression, and self-injury are 3 times as high in the context of intimate partner violence. Research has consistently showed this over many, many years. Suicide attempts are 4 times as high, but people often don't think about what are the contributing factors of intimate partner violence, like entrapment, or experiencing potentially lethal domestic violence and feeling like suicide's the only way out. So there are additional dimensions that are addressable if you're recognizing the role that intimate partner violence is playing. And substance use disorder, 6 times as high in the context of intimate partner violence. We'd done a research review before we'd done the coercion studies, and most of the data is correlational. It doesn't show what the relationship is. So it's really critical to understand that if we're going to intervene in ways that are really helpful to people. So part of the rest of this is focusing on the unique considerations that people experience who are dealing with intimate partner violence. So it's both the traumatic effects of the abuse plus the ongoing risk and coercive control. So there's lots of work on trauma treatment and trauma-informed services, but people aren't thinking about this additional layer that people have to deal with when they're in an abusive relationship. So part of this is, what we're talking about in this context is what we've come to term mental health and substance use coercion, which are under-recognized forms of abuse that are specifically targeted towards a partner's mental health or substance use as part of a much broader pattern of abuse and control. So, if we had more time, I'd say, how many of you have heard of this? How many of you are seeing this? How many of you are addressing this already in the chat? So I'm going to show you data from studies we did in 2012. The report came out in 2014 about what we called mental health and substance use coercion. We did these with the National Domestic Violence Hotline, who at that time was doing what they called focus surveys, called 6-week surveys, which were actually interviews of people who were calling the hotline, not in acute crisis, and really were willing to participate because they wanted their experiences to help other people. So they were just a really critical part of this, and very generous in their sharing of information. So the mental health coercion study was around 2,500 callers. 89% had experienced at least one type of mental health coercion, including 83% said that their partner or ex-partner had accused them of being crazy and used that as a way to undermine them and make them not trust themselves or their perceptions, and also to undermine them with other people. About 73% said their partner actually deliberately did things to make them feel like they were going crazy or losing their mind. So they were gaslighting them. So just think about that. That's a lot of people. About half of those who sought help for any kind of mental health condition or feeling depressed or emotionally distressed said that their partners tried to interfere with their treatment or control it. And then another half said that their partners then threatened to report that they were quote unquote crazy to keep them from getting things they wanted or needing. And often that's a protective order or particularly child custody. So when we looked at the qualitative findings, what we found that there was a whole range, and some of the themes were, one is actively trying to undermine a partner's mental health, make them distrust themselves, calling a partner, pathologizing names, reading to them out of the DSM, trying to diagnose them, using, saying they're bipolar or borderline, trying to convince other people that their partner is mentally unstable or mentally ill, blaming the abuse on the partner's mental health, saying things like, I had to restrain her, she was out of control, and we know that strangulation is one of the potentially lethal forms of intimate partner violence. One of the things people would do is try to get a protective order saying their partner was out of control and violent. Treatment interference is another big issue, trying to influence the diagnosis, speak for the person, coming to treatment with them, Another thing is trying to coercing a partner to overdose and then trying to have the partner committed. For anyone working on a suicide crisis line, keeping that in mind. You know, when you have someone who seems concerned, it seems like it's, you know, that's helpful. There's going to be someone to help keep the person safe. But when it's an abusive partner, it may be completely the opposite, and you have to have different protocols to use. Controlling medications, there was a whole continuum of what people talked about, preventing someone from taking their meds, forcing them to take the wrong meds or to overdose, stealing their meds, calling their partner an addict for taking medication, one person, you know, forcing someone to take an overdose and then having them committed. I mentioned that before. One person said that she had bipolar disorder, and during a depressive episode while she was highly medicated, her abusive partner maxed out her credit cards in her name and threw her out of the house and divorced her. Another person said sometimes their partner would encourage them to take medication for their own purposes. Other times they wouldn't allow them to take medication, or they'd be responsible for getting the meds. And then when they couldn't get them and were symptomatic, then they would report them to Child Protective Services or get a protective order. So there's so many permutations of this. So just thinking about how all of that plays out in your practice is really critical. And then the threats to report or discredit. I'll talk a little more about that earlier, but people make false allegations. They really try to use this against a partner in custody battles. We've talked to lots of judges who are very savvy about this, but say, who am I going to give custody to? The person who looks like they're in good shape, or the person who they've been abusing for years? So there's lots of layers about that where this plays out, and we know that fear of custody loss is a critical deterrent to care. So these are just a couple of things that people told us. He'd tell me I shouldn't get any help or take meds because he didn't want anyone to know about my depression, or he'd say things really softly under his breath. And when I'd ask what he had said, he'd tell me I'm crazy and that he didn't say anything. He told me that if I tried to leave, he was going to take the kids and I'd be in a psych ward. So those kinds of things are constant threats, and people are always having to weigh how much to, you know, if you go to treatment, I'm going to do this. If you get help, if you tell anyone, if you take your meds. For the substance use coercion study, it was over 3,000 callers. And 26%, and these were not people in substance use disorder treatment, these were callers to the DV hotline, said they'd use substances at some point to reduce the pain of partner abuse by their partner. I'm sure the numbers would be much higher if they were talking about a whole, you know, all forms of lifetime trauma. But 27% said they'd been pressured or forced to use alcohol or other drugs, or made to use more than they wanted. So just think about that. How many people are using because they're being forced to? When you look at the SAMHSA-NISDA study, there might be initiation into substance use by a romantic partner, but nothing about coercion. Of the 15% who tried to get help, over 60% said that their partner had tried to prevent or discourage them from getting help. So if you're providing treatment and not thinking about that and factoring that into your treatment plans, it's very hard to, you know, really be helpful to people. 38% said their partner threatened to report their substance use to someone in authority to keep them from getting something they wanted. Often that's Child Protective Services. And almost a quarter were afraid to call the police because their partner said either they wouldn't be believed or because they would be arrested for using under the influence. So again, with the qualitative findings, we saw this continuum of use being, you know, maybe initiated into using and to the point where someone became physiologically dependent, or maybe someone was using because it felt good, and then they were didn't want to stop because they wanted to keep their partner happy, and then they didn't want to make them unhappy, and then they were afraid to deal with the threats that would happen if they when things progress. So there's lots of ways this plays out, and often people become entrapped. Treatment interference and recovery sabotage. A lot of people talked about not being prevented from attending treatment or meetings. Transportation and childcare were withheld, or insurance or funds. So there's that preventing someone from going and then harassing someone into leaving because of all the threats, made it very challenging for people to continue accessing treatment. If someone's going to a methadone clinic and has to keep regular appointments, it's easier to be stalked. Another thing that comes up, that people would have their meds controlled or diverted, and that's often a reason why people would be exited from services. Not being able to keep regular appointments, and then, you know, people have kind of rigid criteria for you can't miss too many appointments, or you're 15 minutes late, you can't come, and not factoring in what may be preventing someone from accessing services. People also talked about recovery sabotage and a partner keeping substances in the home or, using in front of them when they're struggling to be in recovery, and then escalating violence if they try to cut down or stop. Again, the threats to report were very common. And when we were doing this, it was in the beginning of, recognition of the opioid epidemic. There were very specific kinds of things, forms this took, like controlling the person, getting a partner to use to the point where they became physiologically dependent, and then controlling their supply, and then using the threat of withdrawal to coerce them into engaging in illegal activities, or to use unsafely, and then or injuring a partner to obtain pain meds, and then having them go to the ER and get opioids. Jeopardizing custody, housing, jobs, and public benefits. There's lots of ways that that's become specific, even injecting a partner with Narcan to put them in withdrawal and using that as a threat. If you don't do it, I'm going to do that again. So, I wanted to share this slide because, we think about Dr. Krans talked about the neurophysiology of substance use disorder and how it really can change our brains, but we don't think about how an abusive partner can actively provoke relapse as a tactic of abuse, whether it's consciously or unconsciously. So if you think about the circuitry that's involved in exposure to addictive or rewarding drugs, condition cues from the environment, and exposure to stressful experiences, you could see how just experiencing ongoing abuse by an intimate partner can be really challenging to someone's ability to maintain their recovery. And so again, we have this constellation we know that the trauma of IPV is associated with a whole range of mental health and substance use conditions, but we also have to always keep in mind that abusive partners actively work to undermine their partner's mental health, their recovery, and their parenting. And part of how they do that is by controlling treatment and medication and sabotaging recovery, and then using these issues to further control their partners. And one of the things I know we've talked a lot about stigma is leveraging the stigma associated with mental health and substance use as a way to mobilize other systems or other people against their partners. So it's that constellation. Part of why it's their tactics are so successful is because of the stigma that they can play into. So a number of us have been talking about, the fear of custody loss and incarceration are also major deterrents to care. I think I'm talking too fast. So, thinking there's a number of factors, and, on the maternal mental health task force, one of the recommendations was really to have destigmatized ways of screening and talking to patients or clients about substance use in a way that would make them feel more comfortable talking about things that they had a lot of shame or fears about. But part of what a lot of other people were saying is that there's really policies. So it is really risky. It's not just how people talk to you, which is critical, but also what kind of risk are you in depending on where you live. So the policies that lead to criminalization of substance use during pregnancy or criminalization of and pregnancy loss, and then child removal policies that are targeted specifically toward women who use substances. So that's a key factor. But we know that CAPTA, Child Abuse Protection and Treatment Act, it doesn't define substance use as child abuse and neglect. It doesn't consider a positive screen to be child abuse. It doesn't mandate CPS reporting of positive tox screens, and it doesn't require prosecution of use of non-prescribed medication or drugs as child abuse and neglect. So there's lots of things that it's really how people interpret that and/or what states put into their own statutes. But the other piece, and this comes from Sarah Roberts' work, is the role that healthcare providers and behavioral health care providers play in over-testing and over-reporting that is a leading contributor to child removal and criminalization. And then the third piece that, that kind of brings this together is the amplification of harms in the context of intimate partner violence. And this is just some visuals to show the increase that substance use is a major factor in women's incarceration, substance use related crimes, including threats, theft and dealing. So there's lots of, but we also not thinking about how women are coerced into engaging in illegal activities by an abusive partner who's controlling their supply of drugs. This is also, we know that substance use is also a leading cause of child removal in the US. And this is during the first year. You can see where you are and which states you're in. There's also a map, a Brandeis study for disabilities in child custody. Developmental disabilities and psychiatric disabilities are also leading causes of child removal. And this is from Sarah Roberts' work about, they've been doing a lot of training and education of healthcare providers around not over testing and not over reporting. So that, as I mentioned, many reports aren't legally mandated. And that also testing and reporting creates a lot of stress and conflict for people who are making a decision whether to use medication for opioid use disorder treatment during pregnancy, knowing that they might get reported, and having to have strategies in place to support patients and providers. We also know that the people who are most likely to test positive are not the people who are most likely to be tested. And that study, I know Dr. Krans was involved in that study, and that that Black women were less likely to test positive, more likely to be tested. And that testing and reporting is not associated with better outcomes. And as many of you are aware, ACOG and ASAM, urine drug screen recommendations are really only when it's needed for treatment with informed consent. So it's not done as a monitoring or punitive strategy. This is from a study we did with the hotline in 2023, looking really how abusive partners leveraged policies against their partners in the context of mental health and substance use coercion. So again, things we talked about before: restricted access to behavioral health services and spiritual and culturally specific healing supports, using behavioral health issues to jeopardize custody, and making false allegations. You can see very high rates of false allegations. And also using claims about a partner's mental health and substance use condition to jeopardize their housing, benefits, and livelihoods, and to get them in legal trouble. So one of the things people talked about, he made reports that I was committing fraud to the unemployment office and SNAP so I wouldn't have a way to support myself or feed my child. He threatened to report my drug use to my job and professional licensing board. So there's many, many horrible ways it plays out. So again, one of the things that Kelly Lemon has incorporated into the pilot we're doing there is like having tip sheets on how do you advocate with CPS? How do you have letters if Medicaid isn't willing to change a medication to an injectable form that will make it safer, make it more possible for someone to control their medication. How do you get legal advocacy when somebody needs it, when an abusive partner is using their substance use to get them in trouble with the law? So again, this is just looking at, there's all these policies, there's all these practices, and abusive partners leverage all of them. So we need to be mindful about what we're doing and how we're advocating. So the second part is really talking about what it means to have an integrated approach. And, there's the treating of mental health and substance use conditions in a more straightforward way, and recognizing that, for a lot of people or some people, medication and therapy is going to, be life-changing. But for many of the people we're all talking about, life is much more complex. And unless we have ways to address that, people are not going to be able to be safe and heal and recover. So another key component is addressing ongoing risks from IPV and stigma, and then addressing the ongoing risks from services, systems, and health-related social needs, and then facilitating healing and recovery for trauma. So I'm going to talk a little bit about some of these. We've done a lot of work on looking at trauma treatment in the context of intimate partner violence. And one of the things that most PTSD treatments are for trauma, or even complex trauma treatment modalities, are focused on trauma that occurred in the past. And so the question is, how do you heal while you're still under siege? So it's really looking at optimal treatment, layering in all of these dimensions, if we're going to be supportive of survivors who are dealing both with ongoing trauma and ongoing risk. This is a toolkit that we developed in response, it was in 2018, to the coercion survey and what we were hearing from survivors and providers. And it was really designed to, how do you weave in conversations and responses to mental health and substance use coercion into clinical practice? And thinking about, what role is this playing in someone's ability to access treatment, manage meds, keep appointments, and recover. So having this additional layer, and we were thinking people will read it as common sense, and then they'll adapt it into their practice, which of course isn't going to happen in busy practice settings. There's a lot of other dimensions that people often don't think about attending to unique safety, confidentiality, and privacy risks and barriers to care. And as Kelly was talking about beyond screening, how do you develop the skills and the safety to incorporate conversations about sensitive issues into your quote unquote screening and assessments? We know from the Maternal Mental Health Task Force that the interviews and listening sessions they did with people with lived experience, people said, we don't like screening. We're screening for all, postpartum depression and suicidality and substance use, and people don't know what's going to happen with that information, and they don't know if they're going to be judged. So creating a way to have safe ways to have conversations about all of these things is really critical. Strategizing about safety, we often think, if someone kicked, slapped, or shoved, that nobody answers, and often those questions are asked when someone else is in the room, and making a referral. We're not thinking about all these other dimensions of safety. The other critical piece is really having working partnerships with domestic violence programs as partners, not just to refer, and how do you bring them into the mix of doing consultations when somebody's there. Lots of ways to do that. So I'm going to talk about our two pilots very briefly. One is with Dr. Krans at UPMC that we're just about finishing. We're finished and we're writing everything up and developing a whole implementation guide and toolkit and lots of resources that should be available in the next month. And the one with Kelly Lemon in West Virginia that we're still in the midst of. We just got a no-cost extension today, so we can actually finish that one up. But it's really a multi-tiered intervention. So one of the things we talk about is creating safe opportunities to talk about these sensitive concerns. And in order to do that, you have to make your practice setting safe enough for that to happen and offer the kinds of resources that make it possible for busy providers to actually open the door and ask things that they may not know how to respond to or have the resources to provide when things are more complicated than they're able to address in their current role. So part of what we did was, implementing something in a busy clinical setting is challenging. So we did a lot of, we had clinical champions, we did clinical flow mapping to try to figure out who does what where and who could incorporate this naturally into what they already do. And if they raise something that needs more of a response than they have time for in their role, can they do it in a way that's the next person is going to actually be able to take the time needed? So in doing that, we identified a lot of safety and confidentiality risks. For example, in the waiting room, the administrative staff would ask questions, the basic stuff about HIPAA and safe, contact information and sign the consent for your open notes. And we realized that's not a safe place to talk about any of these things. So we changed this to standard rooming alone, or being able to talk to people about, what is safe contact information? Do you want your bills to go, you on your partner's insurance? Do you want them to go there? Do you want us to get information to you in some other way? So it's also a way, just in the initial intake, to raise, is there anyone who might be that you may not want to have access to your information? Is there anyone, does your partner know that you're in treatment? Are they supportive? So without even asking specifically about intimate partner violence, we also learned that, open notes to patient portals are the default position for medical records. And that, we know that abusive partners coerce their partners into sharing their passwords and accessing that information. So again, asking, is there anyone who might be trying to access your medical records that you don't want to see them? And then having a whole conversation about blocking records and how to do that in the EMR, as well as having another way, those conversations. Another is mandatory reporting. Everyone's worried about that, and being really transparent and letting people know what your reporting requirements are before you ask, and coming up with strategies if there are concerns about using medication during pregnancy. Another thing that people hadn't thought about was telehealth safety, and is an abusive partner there? Have they put spyware on? Can you create a code word that you would identify in advance, whether that lets you know that, I have to take care of the baby, pick up the baby, that their partner's there and they can't really talk, or what you're going to do if a call drops, and what they do, they want you to call the police, or they just want to contact you at another time. So there's lots of things that people hadn't thought about. The other piece was around barriers to care. So if you have rigid appointment requirements, people may not be able to remain in treatment, or having flexible medication options so that someone could take an injectable form if their partner is diverting their meds. It also comes up around urine drug screen policies, and if someone's buprenorphine level's too low or they're using something that wasn't prescribed, really being able to factor in why that may be happening and what you can do to support them. And again, all the things around social determinants of health, if people can't get to appointments because their partner is preventing them from doing that. There are lots of ways, as Kelly was saying, to weave this naturally into your conversations, whether you're doing a substance use history, asking about, is there anyone who might try to interfere with, prevent you from coming to treatment or make it harder for you to maintain your recovery. So we're trying to figure out how to naturally weave this into conversations that you're having. So, and I think I talked about some of these. One of the things with the DV programs, they can provide consultation on site. You could call them while you're there. There's lots of ways to not just make a referral that can really enhance your knowledge and expertise and patient care. Another thing we did was create EMR templates, and I'll show you something about that, so that it's embedded in a way that reminds providers, but it also has examples of the kinds of questions, the kinds of responses, and the kinds of, and how to refer, so that all that information is there. And then developing resources for both for providers and for patients. This was one of the PALM cards, the first half of it. So there's a number of red flags that people start to identify, like, maybe we should think about this. Maybe there's something going on that's making it hard for someone to maintain their treatment, or, people losing prescriptions or misplacing their medications, or increasing their use. We also, on this kind of provider, we're making actually bigger than a PALM card because the PALM card was too small to read. So how do you open conversations? Like, many of our patients have told us their partners interfere with their treatment or sabotage recovery. Is that something that you've ever experienced? Or sometimes partners might, and can provide an example, try to convince other people that you're an addict and unreliable, and to undermine your credibility. Or many people have shared with us that their partner pressured them to use substances or use in ways they didn't want to. I'm wondering if that's something that you've ever experienced. And then letting people know that we understand that using substances can be a common way to deal with physical and emotional abuse or pain caused by a partner. And if you've had any of these experiences, we're here to support you. So there's lots of ways to do that in your own voice, but it's normalizing, it's sharing that other people experience this, and being there, letting people know. So one of the ways, and again, letting people know it's not your fault, no matter what society tells you, what anyone else tells you, you always deserve, no one has a right to harm you, and you always deserve to be treated with dignity and respect. So it's all the things that we've been talking about, but also layering that in the context of intimate partner violence, because people are getting, we're getting these messages from society, but they're actively getting them from their partners. And this part is really about some of the strategizing together and safety planning. And I think I talked about a lot of these already. So the EMR, those are really, when an abusive partner is going after their partner in a custody battle, they're going to try to access their records. So how we document is really critical. Documenting, everything we learn about the abuse and coercion is critical. Talking about how people are, what they're doing to maintain their recovery, their strengths, any observations about how well they're taking care of their kids, making sure all of those are in there, but also figuring out how to make sure that those notes are protected. And then the connection to community resources. So our wonderful partners at UPMC, Dr. Diana Sandberg and Alana Hull, created these amazing EMR templates. And this was just one example of how that was embedded. Kelly also developed a whole other set of EMR templates at WVU. So each one takes you to another screen. We also developed these patient-facing posters, and they were, the reason we did it was because the peer recovery specialist told us we needed to do it. When we were looking at everyone's assessment tools, they said, well, we don't actually ask people questions and bring things up. We wait for people to bring them up to us. But because this is really important, why don't you create posters that patients can see, and then they'll talk to us about it. So we developed this whole series of posters, and some are in the bathrooms, and some are, if your partner, you can't be seen alone, you could have a little tear off with your urine screen to let the nurse or the person who's taking that know that that you're at risk and you come up with some other strategies. So this is also something that we're really proud of. And that in the evaluation, basically, one of the things that was really interesting, not only did providers start to implement all the things we were asking them to do, but people learned how to talk to patients in ways that made it safer for them to talk about these issues, and they felt more comfortable, and then the patients felt much more comfortable. So we were, it's really the kinds of things that that everyone's been talking about. How we interact with people really makes a huge difference. And people don't want to do that if they don't feel comfortable, if they don't know how to respond, and they don't know what to do. So I just wanted to highlight very quickly before we end this wonderful approach we're doing in West Virginia. As part of a statewide initiative that involves statewide partnerships with the Bureau of Behavioral Health, who are active partners, and statewide organizations, including the West Virginia Coalition Against Domestic Violence, the West Virginia Perinatal Partnership Drug-Free Moms and Babies Program, and and the Marshall University Center of Excellence Training Program that's housing all of our trainings in asynchronous e-learning modules. And the Bureau of Behavioral Health is bringing in all of their CCBHCs. One of the things they were able to do is put in their CCBHC requirements, partnering with the 14 licensed DB programs, requiring training and partnerships, and in some of the substance use disorder contracts that they control. So let me just go through a couple things. This is, the Kelly's version of we called it SBIRT Plus because we had to put something in our grant, but it's really not screening. It's having conversations. It's having, providing much more complex support to people. And the referral is really a much more, partnership, not just referral. And weaving together the mental health, SDOH, and substance use so that it's really a whole person approach. That's been really important. So the partnership allows us to leverage funds as well and to identify service gaps and think about policy solutions. We have this wonderful workforce platform for training, both the West Virginia one and one that we did with the ATTC Coordinating Center. So we have them both online. And then one of the things we're really excited about is that we had regional teams in all 13 regions of the state that parallel so all the birthing centers and drug-free moms and babies programs, all the DB programs, and all the CCBHCs were meeting regularly in their regions to develop those partnerships so people didn't fall through the cracks. And it's really been wonderful because people have developed real collaborations. They've learned about things they didn't know about. They're doing stuff in the communities together, and they're providing wraparound approaches to supporting people who were, often in other siloed systems. And this is just, I love this from our network analysis we did in April, the increase in collaboration and connection between partners in the regional teams over time. So, part of what we're also talking about is having this like a fully integrated model in clinical settings that many of you have been talking about, but also in communities and with the regional teams, and also with state level partners who can help provide resources and address barriers to address things that are coming up that people need and experiences. And that all the relationships in West Virginia have been really critical to making this work. So again, given all the complexities that women are dealing with in the impact of abuse across the lifespan, unmet basic needs, unique risks associated with IPV, it's so critical to address all of them if we're really going to provide the kind of services and healing and recovery and transformation that we need. And again, centering the expertise of people whose lives are most impacted is really critical to the success of all of these initiatives. So, and I'll stop here. You have my information, and we have lots more tools and resources and guidance on all of this. So, and then lots of other resources if you want them. So.
Thank you so much, Carole, for finishing that up. And thank you to all the attendees who stayed on with us. I will be posting the PowerPoints and recording on the Great Lakes ATTC website by the end of this week. So I just wanted to leave some room open for if anyone has any questions. If you do have any questions, feel free to reach out to the Great Lakes ATTC, and we would be more than happy to pass the questions along to the panelists. And I just want to thank you again, Carole, and the rest of the panelists for your wonderful presentations today. And as always, we hope that you come back and can join us for some more presentations. And we hope to see all these attendees on future trainings. So thank you all for joining us today.